Sriram Chandra Bhanjo Medical College, Cuttack, and spent 2 decades in UK, Europe, and Singapore before returning to India. He has authored handbook on coronary care manual in Europe and also pioneered in areas of intracoronary imaging in early 90s. Besides his professional area in treating cardiac patients and performing coronary interventions for over 3 decades, he has a passion in teaching and propagating heart awareness among the population at large via different print, electronic media, and social platforms. He is actively involved in taking the tertiary cardiac care to the doorsteps of rural Bengal via regular health camps since 2006. Dr. Deb believes strongly that the solution to heart care in India lies in the realm of prevention and awareness in home settings rather than in curative care inside the hospitals. So, without wasting much time, I would hand over the screen to Dr. Binayak Deb for today's webinar. Dr. Binayak Deb, the screen is yours.
Thank you so much for your kind introduction and a very good evening and welcome to all the participants in our webinar today on a very important topic we will be discussing today, that is the hypertension management in patients above 55 years, or which means usually we are actually taking out the younger hypertensives in this situation. And we will be reassessing and re-evaluating the changes and the therapeutic options which we have in front of us based on evidence base and also on clinical trials and also the real world scenarios which we physicians and cardiologists, the way we treat patients. So why is the treatment of these elderly, I wouldn't say elderly, 55 we are not elders anymore, but we are not young either. So why in this category and above 55, why is it different, and what is so different about treating these patients with blood pressure, high blood pressure? So usually the young hypertensives or the patients whose blood pressure is high when they're in their 30s and 40s and even in the 20s, usually if we call them, take out the secondary causes of hypertension and concentrate on essential hypertension, then we know that the neurohumoral hormonal influence and the raised cardiac output secondary to that causes the hypertension. It is not much of the cardiac bed or the cardiac vasculature which is contributory to the hypertension. But as the age increases, we know that with the advancement of atherosclerosis, which is a normal process, particularly for the Southeast Asian population, the blood pressure starts rising. And so also the treatment scenarios while we treat this kind of patients. So in our first case, we have a 57-year-old male, an ex-smoker, which means he has a cardiovascular risk factor, sedentary lifestyle, another cardiovascular risk factors with a family history of hypertension, the third one, and his office blood pressure is 162/88 millimeters of mercury. If you see his metabolic profile, his serum electrolytes, GFR within normal limits, his ECG, the sinus rhythm, and there's no ischemic changes, and echocardiogram shows grade 1 diastolic function with a normal ejection fraction, which means this is a typical Indian patient who's 57, office goer, sedentary lifestyle, ex-smoker, and hypertension. So he's got about 3 out of the 5 risk factors for cardiovascular disease. So how do you treat this patient? So let us just concentrate for a moment that office blood pressure, which means the blood pressure which is taken inside the hospital. So what is the cutoff? So the guidelines which says, I mean, if you consider the European guidelines, if you consider the American guidelines, if you consider even the Indian guidelines, anything above 130/80, we are in these realms of actually high blood pressure or hypertension. And anything about 140/90, this is something which we call grade 1. And anything above that is grade 2. And anything above 180/120 is actually an hypertensive crisis. This is how we stage hypertension. But is the office blood pressure or the blood pressure which you measure in the hospital, is it validated? Can you actually make a diagnosis of hypertension just from one blood pressure reading? The answer is no. So what do we do? I mean, the guidelines suggest that you take at least 3 readings about 10 minutes apart while you're taking the history, and then summate and take an average of that reading. Or if you suspect that this is not going to be a real blood pressure reading, then you take to an ambulatory blood pressure, which means that the patient goes home and he's in his normal environment, and you come back with a blood pressure which is 24 hours ambulatory blood pressure. The third option is actually taking the blood pressure at home, which is called blood pressure, home blood pressure readings. So these are the 3 ways we can actually measure the blood pressure. In this particular case, we have blood pressure over 162 over 80 to 8 millimeters of mercury. So what do we do? So the question remains, so why do patients of hypertension above 55 years needed to be treated differently? Because as I just mentioned before, the young hypertensives, the mechanisms why the blood pressure is high is because of hyperemic or overexcitable state, because of the neurohormonal influences, and also that causes the other problems to happen. It is not that young hypertensives do not have cardiovascular disease, particularly in our subcontinent, but say a scenario where these patients have normal cardiac status but still has high blood pressure. So the treatment scenario is definitely going to be different for that patient compared to somebody who is above 55 or maybe 60, maybe 65, and the neurohormonal influences are blunted in this kind of patients, and the cardiovascular bed with the atherosclerosis on board takes over. So the 2 scenarios are different. So obviously, when the scenarios are different, the treatment modality should be different. So let's examine whether that's what's happening or not. So what are the different pathophysiological characteristics when somebody presents with high blood pressure at the age of 55? You have an entity called isolated systolic hypertension, which we are going to discuss in a while. You've got a white coat effect, which is a white coat hypertension, which means when somebody comes to the hospital, they are very anxious, and there is a blood pressure surge in some cases, and that's called white coat hypertension. As I mentioned, you've got arterial stiffness, which is due to age. You've got atherosclerotic processes inside the different vessels of your body, which could be cerebral, it could be renal, it could be in your heart, and you've got endothelial dysfunction as well. Your total peripheral resistance increases. The sodium sensitivity is another issue which we will be discussing, which contributes to this high blood pressure in the elderly individuals. You've got also orthostatic hypotension and a pulse pressure. And what reduces the cardiac output and the heart rate reduces? You've got a renal blood flow which is reduced. You've got low plasma renin activity, and also the angiotensin 2 levels. The arterial compliance again reduces with age, and so does the diastolic blood pressure, which gives you a wide pulse pressure. So these are the reasons, different pathophysiological characteristics basically in elderly hypertensives. So the result of raised systolic blood pressure, you have the stiffening of the arteries, as I just mentioned before, where if you see the first slide, it is normal, and then you have a diminished distensibility, and then it increases, and that causes the stiffness of the arteries. And then on the right hand side, you see low plasma renin activity, and supine plasma renin activity and aldosterone plasma renin levels are a function of a healthy normotensive people. So that's why in these patients, elderly patients, the RASI is actually less effective. So the RAS inhibitors are beta blockers. So the RAS inhibitors and the beta blockers becomes less effective, which means the ACI inhibitors, the ARB, the aldosterone angiotensin 2 receptor antagonist inhibitors, so and the beta blockers, they're less effective in the elderly age group of patients. But we also know that some trials have shown that beta blockers is actually not the first line of treatment for treating elderly hypertension anymore, and that is affected with some few trials. So you have reduction in the number of nephrons with age, reductions in plasma renin activity, and that's why the RAS inhibitors and the beta blockers become less effective with increasing age. So as I mentioned, the growing importance of systolic blood pressure, which means we are talking about a scenario of isolated systolic hypertension. And with increasing age, the diastolic component of the blood pressure assumes lesser significance compared to the systolic blood pressure. And that's the concept of systolic hypertension. And in fact, about in 99% of the hypertensives in the elderly, the systolic component of the blood pressure is actually significant, whereas about 60% of the patients, the diastolic component of the blood pressure is significant. And the reasons for the systolic blood pressure to be significant is because of the hardening of the arteries, the lesser compliance of the blood vessels, the systolic component goes up. And that actually has importance in the outcomes, which in terms of mortality, in terms of myocardial infarction, heart failure, renal failure, and so on and so forth, and other comorbidities as well. So what do the national and the international guidelines recommend as regards the treatment of blood pressure treatment in the elderly? Interpromide is actually the preferred reference diuretics in guidelines around the world for treating hypertensive patients above 55 years. So this is the guidelines. We have several guidelines actually which we refer to. We have JNC guidelines. We have guidelines from European countries. We have guidelines from the American councils, and we have Indian guidelines as well. So all these guidelines, they have been talking about the diuretics being actually the first line of treatment in elderly hypertensive patients. Now, how many of us actually treat elderly hypertensives with diuretics as a lone drug in the as a first line of treatment? We don't actually in the real world practice. We normally give different kinds of combination drugs. Probably some 30% of patients do have a combination of diuretics and say calcium channel blocker or a ARB or a ACE inhibitors, but very rarely we treat patients with the first line as a diuretic alone. So we need to actually discuss this and why Interpromide has been proven to be one of the superior drugs in randomized controlled trials showing cardiovascular benefits, and that being more potent than the other thiazide group of drugs like the hydrochlorothiazide and the chlorthalidone that we need to see. Now, the National Institute of Health and Care Excellence, which is a NICE, they have given some good guidelines which supports the use of Interpromide over other commonly used diuretics. In 2011, mind you, what they told was that chlorthalidone and Interpromide, either or, could be used as a thiazide group of diuretics, and which they later changed in 2019 in the publication of 28 August, that if you're starting or changing the diuretic treatment for hypertension, offer the thiazide-like diuretics such as Indomite in preference to conventional thiazide diuretics, which is a change of stance where they did not mention about the chlorthalidone, and for good reasons, I'm sure. So the algorithm, which has been shown in the 2019 Indian guidelines on hypertension 4, that says that for treating younger patients, you start with either a beta blocker or a ARB or a ACE inhibitor. But if you're treating older patients, then calcium channel blockers or thiazide group of diuretics, or a calcium channel blocker plus thiazide group of diuretics. If that does not work, then you add the ACE inhibitors or the ARBs along with the calcium channel blockers and the thiazide. So it's a kind of a reverse when you are treating from younger to the older patients, in the terms that the diuretics become a very, very important first-line therapy while you are treating these kind of patients. Now, what is the salt-sensitive nature of the older population I just mentioned in the second slide? This means the handling of the salt capacity by your kidneys. So when people are young, the kidneys are able to actually take the salt which is required and throw out the remaining salt which is not necessary by diuresis, by form of the urine. But if there is a derangement of the kidney function, then what happens is that filtration process suffers, and in that case you have a patient whose salt sensitiveness decreases. So in older population, you have a tendency for the salt sensitiveness to decrease in the sense that in these patients they retain sodium, and if they retain sodium, the water volume goes up, and that causes the blood pressure, not only the blood pressure, but also comorbidities like heart failure if his heart is compromised, you've got kidney problems and other problems. So there again, the treatment of choice for these patients are always diuretics as a first choice. And from there, which diuretic to choose, I think we will discuss in the later slides. So patients with uncontrolled hypertension above the age of 55 or 60 or 65, the treatment advised is Indomite sustained release 1.5 milligrams, and let's find out why. What are the clinical evidences for supporting Indomite? So if we see some trials, we see that in the NICE guidelines, it's shown, and also the meta-analysis of 80 trials in 10,818 patients, plus the Allahabad trial, these showed that the diuretics as the first line of therapy actually gives a lot more reduction of blood pressure compared to the ARBs, ACE inhibitors, calcium channel blockers, beta blockers, etc. And of the diuretics, if you compare, you see that the Interpromide of blood pressure compared to, say, a high, right, and as told in the NICE guidelines. So the unique mechanism of action of Interpromide is because Interpromide, unlike vascular effect and about 5, the diuretics act in the distal convoluted tubule, and that's how the diuresis works within sodium exchange mechanism. In the case of Interpromide, what happens is the first part of reduction of blood pressure because of the diuretic effect, but the second part, because it's a long-acting drug, the second part is actually it is effective by changing the endothelial effect. So it has some positive effect on the vascular endothelium, and that is one of the most important cardioprotective reason how the Interpromide actually works and protects the hypertensive patients, not only by reducing blood pressure, but by also reducing the cardiovascular events, i.e. myocardial infarction, heart failure, etc. So if you see these studies, this is a study called PASS study where there's an effective blood pressure reduction and improvement in the quality of life in Indian patients. We had 15,045 patients between the age of 40 to 70 years on Indomite, sustained release 1.5 milligram, and it showed a significant reduction in systolic blood pressure up to 31 millimeters of mercury, and also the quality of life, as in the sleep was disturbed, there was emotional problem, lack of energy. These things also had some positive effects with this drug. And then we had the hypertension trial, which is, and it has been shown that WHO and the international guidelines for hypertension, and it showed that there is a 21% reduction in thing, and then you have 64% reduction in heart failure, which is significantly different, and then you have a 23% reduction in cardiovascular mortality. So if we move on to another trial called LIVE trial, here the Interpromide sustained release has shown that it causes reduction in left ventricular mass in patients with LVH as shown with echocardiogram, and it's a 5.8% reduction. And this is a very important study, the Nestor study, where Indapamide SR sustained release has been compared with enalapril 20 milligrams. And what it shows was that there was a significant reduction of albuminuria, particularly which protects the kidney in type 2 diabetes patients with hypertension. And also it shows that there's a good tolerability profile of the Indomite, because any drug, when we are giving, we have a risk-benefit ratio, and the risks are whether there is any side effects or not, and that is very, very important. So diuretics has been notorious. The labeling has been notorious because they have been told that it causes metabolic disturbances in any patients, particularly elderly patients with hyponatremia, hypokalemia, and other increase of sugar causing diabetes, and so on and so forth. So that notoriety actually has been passed on to every diuretic, but all diuretics are not the same, because Indapamide is actually a group of thiazide-like diuretic. Thiazide diuretic and thiazide-like diuretics are two different propositions altogether. So Indapamide is actually a thiazide-like diuretics, and it is metabolically neutral, which means that the lipid and the glucose levels on patients on Indapamide are actually remain stable. They do not fluctuate much. And also the serum potassium, uric acid, glucose, and creatinine also remains pretty good. So the Nestor study has showed that it's efficient with no changes in plasma fasting glucose, serum sodium, potassium, creatinine, lipid parameters, with 99% of adherence rate. So different trials like the efficient trial, the HIVET trial, and Nestor trials have given a similar good tolerability results, particularly with Indapamide. So what does the recent evidence say about these drugs? They have shown that actually the Chlorthalidone has quite a bit of problem, though it is not a thiazide diuretic, it's a thiazide-like diuretics. So it has got problems as evidenced by the LEGEND study. The safety profile is an issue with hypokalemia, hyponatremia, acute and renal failure, chronic kidney disease, etc. So the question remains that are all diuretics equal? And the answer is no, because if we see the diuretics, the unfortunate bit is that we do not have much head-to-head trials of one diuretics versus other. We have got trials where actually the diuretics have been combined with drugs like other calcium channel or ARBs or ACIs, but all these combinations are usually with a hydrochlorothiazide group of drugs, and very rarely with a chlorothalidone, and with only one drug, which is Coversil Plus, which is combined with Indapamide. So basically, we do not have enough trials and randomized controlled trials and data right now to say that all diuretics are not different. We can postulate that. We know that their mechanisms are different, but they are not the same. So if you compare the three, as I mentioned, the Natrelix SR, which is the Indapamide, and Chlorothalidone and hydrochlorothiazide, new onset diabetes, you've got a chances of 11.6% increase with Chlorthalidone and also with hydrochlorothiazide, but it's neutral as far as Indapamide is concerned. And if it is hyponatremia, it is minimal risk. If it is Chlorthalidone, it is pretty high and moderate with hydrochlorothiazide. Same with hypokalemia. So basically, there is a lot of electrolyte disturbances with this group of diuretics, and that's why a lot of medical professionals have grouped the whole diuretics into one and have not taken the time to actually differentiate between the different kinds of diuretics. So if you have the follow-up of patients with uncontrolled hypertension in 1 month, the blood pressure is coming down, as the electrolytes, metabolic parameters are neutral, and the glucose and the creatinine is not affected. Patient is motivated to implement the lifestyle modifications as well. So now the combinations of two drugs we have the efficient study where actually the patients were given a combination of Interpromide, SR, amlodipine. So basically, we do not have much drugs whereby and trials whereby we have seen head-to-head comparisons or combination being looked into. But what has happened is the reality is that very rarely do we prescribe the diuretics, Indomite or Chlorthalidone or hydrochlorothiazide as the only single drug, calcium channel blocker or the I think the answer is an emphatic yes, and I have a feeling that that we need more trials. That's not for sure. We need more data to convince our medical fraternity, and also our medical fraternity needs to be aware that of this wonderful drug which is available today in our armamentarium, which is Interpromide, which has got a good safety, it's got a good tolerance, got a good efficacy. And the most important is that because we have elderly patients with cardiovascular problems, with renal problems, with other diabetes, with other comorbidities. So you need a which can actually basically, as we await for more trials to happen, the takeaway is the stiffness of arteries and low renin activity lead to increased systolic blood pressure, poor control rates among patients above 55 years. Various Indian and international guidelines suggest use of thiazide like diuretics for these patients, such as Indomite. And Indomite is a metabolically neutrally diuretic, best in class tolerability, and areas suggesting chlorthalidone. It is better than chlorthalidone safety profile and is even lesser than hydrochlorothiazide. So basically, with these words, the treatment doesn't bring back the risk to that of someone without hypertension, but high blood pressure raises the risk threefold, and treatment reduces it by 2.5%, as quoted by Dr. Walter Willett. Thank you so much for attending.
Thank you, Dr. Deb, for the presentation. So we expect questions from doctors and delegates. So you can unmute and ask the questions, or you can type the questions in the chat box. Let me see if there are any questions in the chat box. Yeah, so we have a few questions here in chat box. So I'll make things easy for you. I can read the questions from here. So the first question is, challenge in managing hypertension in patients above 55 years in your day-to-day clinical practice and the treatment regimen in managing such patients. Dr. Deb.
Of course, the challenge when you are dealing with patients in our Indian scenario is, I believe, is that they come to us sometimes pretty late. But if you're in an urban setting, obviously, probably you get the patients early on. But very rarely we see patients coming for checkups and having incidental hypertension detected. I think it's very important that if you have a family history of hypertension, and if you have cardiovascular risk factors, you need to check your blood pressure pretty early on in life. The other challenge is, of course, our compliance to medications from the patient's point of view. The expenses is an issue, and we do not have a very good way of tracking and auditing exactly how our patients take their medications. Very big challenge as well. The thing is, I think the patient education and awareness is actually the responsibility of the doctors. So that needs to be proliferated to the last mile, which means that it go to the patients in the rural areas as well.
So you in fact, we have also done many camps with you in rural areas, and in fact, your experience in managing these hypertensive patients from rural areas, particularly where you get a lot of the patients from rural areas, and they come to you for treatment, and how do you manage them? Is it different managing patients from an urban setup?
Yeah, I think the stimulus for the high blood pressure is definitely a different if you compare urban setting to rural setting, because our stresses are different and their stresses are different. We probably sometimes have stresses of too much, getting too much, and they have the stresses of probably being the underprivileged section. So I think these are the two scenarios. But I think in if you compare, I think the dietary patterns probably it is better off in the rural areas if you compare to the urban areas, because our children, our generations, they thrive on fast foods and diets, which is very, very high on sodium content. And we know the sodium is like a poison to your vascular system, particularly your kidneys, your brain, and your heart. So I think in my experience in treating both rural and urban patients in a scale of 1 to 10, I think the difficulty we face in treating the urban patients is probably much, much higher. Challenges are much higher compared to the rural patients, because the only problem there is actually detection of the hypertension, because they come to you pretty late. So unless they have pretty big symptoms, we see a lot of patients, either they come with a heart attack, or they come with a brain stroke, or they come with a kidney problem, and then the hypertension is being detected. So I think what we need is that more and more people, the medical professionals, to be actually visiting. You don't need to be tertiary care doctor. You just need to be just secondary care doctor, and even the basic doctor can actually be taking care of the blood pressure problems in the rural areas.
Yeah. Now we have another question. In elderly hypertensive patients, which one is the best drug in managing secondary stroke prevention?
I think in secondary stroke prevention, you need to look into the calcium channel blockers to begin with, because I think if you're talking about heart problems and heart failure, definitely the diuretics, Interpromide would be first on the list. But if you talk about management of stroke prevention, my first drug would be the calcium channel blocker.
Another question is, sir, do you have a reserved patient profile for Chlorthalidone and Interpromide? If you do, what are the clinical differences between these two profiles?
See, with the data which we have, as I just mentioned in the slides, Chlorthalidone is something which probably I would not prescribe. And if I need to have a combination, and when I have Indapamide in my hand, I don't think I need to go back to Chlorthalidone. If I need to give just simple diuretic, inexpensive diuretics, it is better to give hydrochlorothiazide compared to Chlorthalidone. And if I need to to escalate the diuretic response with a cardiovascular protection, definitely Indapamide would be, as per the trials and data and evidences, Indapamide would be much higher than Chlorthalidone, which I mentioned in my talk has got so much of side effects.
So as of now, we are having no questions in chat box. So we can wait for a few minutes. And meantime, Dr. Deb, do you have any message for Sardia?
Yeah, I think we need to engage. You have been doing that. As you just mentioned that you come with me to the heart camp. So basically, we need to engage, and I think what I do in a very small scale. I think if we can expand this horizon and to different rural areas as a pharmaceutical entity, I think you can dwell on how to spread the awareness with leaflet campaigns, with electronic campaigning, and also to make that your drugs are available to the last mile, which means to the shops and pharmacies in the rural areas. There's no point in having the drugs only in your urban counters and suburban counters, because 80% of our population in our country, they live in the villages, and we think that they are not able to purchase the medicine. But if it's an effective medicine, and if they think that it is going to help them, they'll definitely purchase it. So I think it is important that every pharmaceutical should make a big effort to make their products available to the last mile person in the country.
So, Dr. Dev, we have another question. Is Interpromide only preferred in elderly hypertensive patients? What if you use Interpromide in younger hypertensive patients? I mean,
see, younger hypertensive patients, it's a very good question, because as I mentioned, the younger hypertensive patients, I'm just talking about patients which I talked about, the beta blockers and the ACE inhibitors, and who do not have, say, a cardiac failure or a heart condition which will cause for them to accumulate water inside the body. So if that kind of patients comes, I think you can take them on the ARBs and the ACE inhibitors as the first line of treatment. But if any patient who's got a reduced ejection fraction, cardiomyopathies, ischemic cardiomyopathy or dilated cardiomyopathy or valvular problems, where they have a problem of handling sodium and accumulating water in the body, definitely if you need to have a diuretics, if you need to have a diuretic which is safe, then Interpromide would definitely score over hydrochlorothiazide and chlorthalidone. And particularly in the Indian subcontinent, say whether it's India, Bangladesh, Sri Lanka, whichever country, even Southeast Asian countries, we see a lot of patients, young heart patients with acute heart attacks. And mind you, if we do not control hypertension in the next 10 to 15 years, this is going to be an epidemic which is going to blow on our face very, very hard.
Yeah. So I think this is the last question we had, and there are no more questions in the chat box. So thank you, Dr. Binayak Deb, for your excellent deliberation. It was a highly interactive session, and in fact, we learned many things from you, and the delegates were, of course, happy to attend this wonderful session of yours. So I thank the delegates and doctors for taking time off their busy schedule and attending this webinar of Dr. Binayak Deb and making it a success. And we'll be meeting you soon in future with Dr. Deb. So thank you all. Thanks very much.
Thank you. Thank you very much, and have a good evening.